Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary, for the medical knowledge to general people and for reference to medicos. Today I am going to discuss about the adrenal insufficiency. Adrenal gland lies on the upper pole of the kidney. Each gland consists of an inner medulla secreting adrenaline and noradrenaline and an outer cortex formed of three layers. From outwards they are zona glomerulus, fasciculata and reticularis. Three groups of hormones are identified according to the metabolic activity. As a whole, about 40 steroid compounds have been extracted. Principal hormones are cortisol, corticosterone, aldosterone, androstenedione, androsterone and dihydroepiandrosterone. Androcorticotropic hormone, adrenocorticotropic hormone, A.C.T.H, is the substance of influencing the secretion of cortex. It is the insufficiency of the adrenocortical hormone and the sequelae of the condition. It may be classified into two types. Primary, from the acquired disease of the adrenals, Addison's disease. Congenital, due to congenital enzyme deficiency in relation to synthesis of adrenocortical hormones, congenital adrenal hyperplasia. It may be secondary to failure of A.C.T.H secretion due to pituitary or hypothalamic disorders. Addison's disease. Common causes are the autoimmune adrenal failure and tuberculous destruction of the adrenal. When acute adrenal failure occurs during an infection with septicemia, usually meningococcal, it has the eponym Waterhouse-Friderichsen syndrome. Clinical features. Onset may be acute or chronic or commonly acute following upon chronic. Chronic primary adrenal insufficiency, weakness, weight loss, hyperpigmentation of the face, neck, back of the hands, knuckles, elbows, knees and skin creases due to the MSH or vitiligo patchy areas of pigmentation surrounded by increased pigmentation. Hypotension and gastrointestinal disorders. As disease progresses, anorexia, nausea and vomiting, pain, alteration with diarrhea occurs with increasing frequency and may be mistaken for acute abdomen. Sensitivity to drugs like morphine, etc. Hypotension, syncope and vertigo are present. Reactive hypoglycemia after a carbohydrate meal. In females, loss of hair, amenorrhea, premature failure of ovarian function due to steroid secreting cells of ovary. Secondary adrenal insufficiency. Adrenal insufficiency secondary to the organic pituitary disease generally show clinical features of impaired gonadotropin secretion or growth hormone secretion if the patient is of appropriate age. It may be secondary to the prolonged use of corticosteroids. Clinical features. Pallor, skin is fine if there is no hypothyroidism. loss of axillary or pubic hair, blood pressure is normal. In absence of A.C.T.H, zona fasciculata reticularis undergoes diffuse atrophy. Congenital adrenal insufficiency. It may be present at birth, infancy or childhood, depending on the precise type and severity of the hydroxylase enzyme deficiency. It in turn causes hypersecretion of A.C.T.H. At birth, the child may show signs of virilism, hypertrophic clitoris and fusion of labia. In male child, it may be severe and may cause death. In childhood, if the enzyme defect is less severe, infant may survive and symptoms are seen in childhood. Precocious puberty. Growth advances at first and restricted later due to early fusion of epiphysis. Investigations. Metabolic effects. Addison's disease, alteration of serum electrolytes with depressed sodium and elevated potassium levels. Some degree of hypoglycemia. Cortisol level. Diurnal studies. In early stages, determining the presence of or absence of diurnal rhythm is in plasma cortisol level by taking blood at 9 hours and 23 hours for 2 or 3 consecutive days for determination of fluorogenic corticosteroid levels before the starting of treatment. Low level of absence of diurnal rhythm could be due to a lesion at any point in the hypothalamic pituitary adrenal cortex. Stimulation test. By administering the A.C.T.H or its potent analogs, tetracosactrin depot, given IM 0.1 mg, the plasma fluorogenic corticosteroid level may be measured at 30 minutes, 60 minutes and 5 hours after the injection. The basal level measured should be 5 micrograms per 100 ml. At 30 minutes it should be 7 micrograms. If more than 18 micrograms, it suggests an abnormality and a test repeated on following 2 days. In secondary adrenal insufficiency, there is a stepwise increase in cortical levels on each day. In primary, there is no response. Insulin-induced hypoglycemia, blood glucose and plasma fluorogenic corticosteroid level should be estimated half-hourly for 90 minutes. Normal peak value of the latter show a mean of 28 micrograms per 100 ml with a range of 7 to 24 micrograms per 100 ml. Useful information about growth hormone and prolactin can be obtained from the same sample. It is the most sensitive test among the investigations. Inference. Normal diurnal rhythm of plasma cortisol response to insulin, hypoglycemia. There is no abnormality of the hypothalamic pituitary adrenal cortex. If adequate insulin hypoglycemia does not give a normal rise in plasma cortisol, it is sometimes possible to localize the lesion further by proceeding to metyrapone and lysine vasopressin tests. Metyrapone test. The oral administration in a dose of 750 milligrams 4 hourly for 24 hours therefore produce a fall in the secretion of cortisol, which activates the hypothalamic pituitary axis via the feedback mechanism so that the active secretion of A.C.T.H is increased. Consequently, 11-hydroxycortisol which is released into circulation. After metabolizing in the liver, excreted in the urine in the 17-oxogenic steroid fraction, the plasma fluorogenic steroids and 24-hour urinary 17-oxogenic steroids should be measured during preceding 48 hours. The 24 hours during the administration of metyrapone and following 24 hours. If the urinary fluorogenic steroid is low and a rise in urinary excretion of 17 oxygenic steroids, hypothalamic pituitary axis is normal. The latter will not occur in lesions of hypothalamic or pituitary that affect CRF or A.C.T.H secretion. Lysine vasopressin test. It is not much preferable for diagnosis. Pyrogen tests. These tests are not reliable for diagnosis. A.C.T.H measurement in plasma. If in the presence of low levels of plasma fluorogenic steroids, the plasma A.C.T.H is high, indicating primary adrenocortical insufficiency. The measurement of plasma A.C.T.H level facilitates the study of the hypopituitarism, as it is no longer necessary to use the patient's potentially normal adrenals in an vivo bioassay. Treatment. All patients with insufficiency will require replacement therapy with a glucocorticoid, while the majority of patients with Addison's disease will also need a mineralocorticoid. In congenital hyperplasia, full replacement does not doses of glucocorticoid and mineralocorticoid if the nature of the enzyme block demands it, will suppress A.C.T.H secretion and prevent the excessive formation of metabolites with the consequent regression of the clinical features. Cortisol is the drug of choice for routine glucocorticoid replacement therapy. Cortisone acetate, though widely used, it has disadvantages. Other drugs are prednisolone, dexamethasone and betamethasone are useful in keeping the patient in good health, while adrenal function tests are being done. For maintenance treatment, it is best to give the glucocorticoid medication in a regime which mimics the normal diurnal variation of cortisol output. Standard dose is 20 milligrams at morning and 10 milligrams in the evening. Other drugs are cortisone acetate, fluorocortisone, DOCA, doxycortisone trimethyl acetate. Secondary adrenocortical insufficiency. Same regime is used without the mineralocorticoids, as adrenocortisone secretion is little affected. Acute adrenal crisis. It is a medical emergency, and if properly treated with hydrocortisone, hemisuccinate IV and intravenous fluids, will have good recovery. If there is infection, must be controlled. 5% dextrose to control hypoglycemia and isotonic saline to control sodium loss. Hydrocortisone hemisuccinate is best given parenterally over the first 48 hours till gastrointestinal system settles completely. That's all about the adrenal insufficiency. And in the next video, I will discuss about some other disease. Thank you.